We're on a journey in Kaiser Permanente to be the nation's best mental health and wellness and addiction care program in the country. Part of that journey, very explicitly, is to put the voice of the patient, the member, the consumer at the center of what we do. And with that, I want to lead us into a discussion about that with two guests that I'm really thrilled to introduce to you. Karis Merrick is the Director of the Office of Consumer Affairs for the Substance Abuse and Mental Health Services Administration. She holds a master's degree in organizational psychology from the California School of Professional Psychology of Alliant International University and a master's degree in business administration from Case Western Reserve University. Karis, do you want to come out and join us? Karis, you are sitting second chair, right behind me. And then Mary Giliberti is the Chief Executive Officer of the National Alliance on Mental Illness. You heard Pete Early talking about NAMI earlier. Prior to joining NAMI, she served as a section chief in the Office for Civil Rights at the U.S. Department of Health and Human Services. She holds a bachelor's degree from Harvard College and a law degree from Yale Law School. So, welcome, both of you. And I'm going to switch our cards, Mary.
Oh, okay.
But thank you. I wanted to sit over there anyway.
I figured you were a question.
So, I just want to open up by giving you two a chance to talk a little bit about yourselves and your organizations. I'm going to sit like this so I can see you both. So tell us some of your story. Tell us about the organization that you're with now and its role, and why is it important to do what we're doing today? Karis, do you want to start?
So I'll start, but I want to sort of start in a different way because I'm introduced in my organizational role, and I'm not here representing my organization per se. You'll hear from our new Assistant Secretary for Mental Health and Substance Use, Dr. McCants-Katz, later on this afternoon, so I do not want to steal her thunder. So I want her to have all the thunder, and, and I'll take some lightning. I don't know what I'll take. But anyway, so what I prefer to do is just introduce myself to you as just as an individual, like who am I as a person? And I had some slides. I don't know if they're there, but I'm a very visual person, so this helps me sort of keep on track.
We do have your slides if you want them.
So as you see, I just said what I said there, so I am on track without the slides, but now you see it. All right, so you can go to the next slide. So, yeah, that is cute as pie, is it not? Everybody has to go, aw, right?
Aww.
Okay, participate, it's all good. So anyway, that's me, and I'm, before anybody knew anything about me, I'm a little girl. I have a brother, so I'm a sister. I guess he's a loving brother. However, he may be sucking the life right out of me at that moment. I do not know. I am clearly African American. I'm a person of color. I'm also Muskogee Creek Indian. The picture was taken on a tabletop in Bremerhaven, Germany, which is where I was born. So I'm an army brat, or known as a global nomad. And later on in life, my family is huge, and that's why I kind of love this picture, because it contextualizes everything about me that I bring to the table that's important to me, whether it be in my work role or whether it be in my quote-unquote patient role. So I am a person with lived experience of a mental illness, and I have a diagnosis of schizophrenia or schizoaffective disorder, depending upon who you ask and what day you ask them. And I think those are some of the things that will really ground some of my discussion here with you today.
Hello, everybody. I'm Mary Giliberti. I'm the Chief Executive Officer of NAMI. And I guess I thought I would tell you a little bit about the early part of my story, because it's kind of relevant to why I think it's so important to talk about mental health and mental illness. So when I went to college, I didn't know anything about mental illness. I hadn't had any experience with it, know anything about it. And I met a dear friend who became one of my suite mates who had major depression. And I basically said and did everything NAMI tells you not to do. You can look it up on our website. I did them all. Cheer up, look on the bright side, look where we are, everybody loves you, all these things that only served to let her know that I didn't have a clue what she was going through. And so, I let her feel alone. And during my last year of college, she attempted suicide. We graduated. She was supposed to come and visit me, and she canceled. And then she died by suicide. And for me, this issue is really important because it's so personal and important to be that support for somebody, and also because it taught me the really hard way that these illnesses are lethal. And I think we forget that sometimes, that people think of these things as things you can will your way out of or not that serious, and yet they are very serious. And we can make a tremendous difference if we get in early, because 75% of these conditions onset before age 24, so we can make an enormous difference. And that's what at NAMI we really try to do. So we have, I would say, 3 basic beliefs. One is you are not alone, right? That is core to who we are and what we do. So we say to families, to people with mental illness, you are not alone, and we teach everybody else how to make sure they don't feel alone as well. We also believe that knowledge is power. So we spend a lot of our time empowering people by teaching them. We teach them about the conditions, we teach them about the various kinds of treatment, and we help people help themselves. We talk a lot about how we help people build better lives. We don't build it for them. And then finally, I would say we fight injustice, because at the core, we believe that what happens to people with these conditions is fundamentally unjust and wrong. And you heard it this morning. I mean, there are no other conditions that I can think of where you wind up in jail because you are so ill. There are no other conditions that I can think of where the shortages are as critical as they are in our field. I recently had the privilege of being at a child psychiatry reception, and somebody said to me, you know, you look kind of overwhelmed, and I said, I can't believe there are like child psychologists, psychiatrists. I spend so much time trying to find them. I felt like I was in a room of unicorns. And that's just fundamentally unjust. And as the CEO of NAMI, I take calls all the time from families and individuals, all the time. The first thing I ask them is, what's the issue? The second thing I ask them is, do you need it covered by insurance? American Heart Association's not asking that question. American Diabetes Association's not asking that question. And someday, I don't want to be asking that question.
Yeah. And I just want to add about the workforce issue. You know, when so I'll just say in my role in the Office of Consumer Affairs at SAMHSA, the role is to represent the lived experience, the consumer voice, as well as the adult family voice, because we do have a child and adolescent family branch that represents parents of transitional age youth and children. But as a person with lived experience, when I moved here 4 years ago from Los Angeles to the DC area to take the job, I had to find a new psychiatrist. And I'll tell you, there are plenty out there, but as soon as they heard my diagnosis, there aren't plenty out there. So as I think Pete was saying, you know, and here it is, you know, 2017, going into 2018, my psychiatrist is still in California, because it's very, very difficult to go. And they'll say, come see me, and I stopped going to see them, and I had to ask them first, do you work with people with schizophrenia? And the answer is no. So access is one thing, building a workforce is another thing, ensuring we're asking the right question about what skill sets and the folks that people are willing and trained to work with is, I think, another deeper question. It just can't be add more psychiatrists. I think that's going to be really a critical thing.
Absolutely. I mean, having them actually treat people who have the most serious conditions. And then just trying to find out who has the evidence-based practice that you might be looking for whatever condition it is that you have, is another whole area. I mean, I think about it, I know more about the food I eat because they make them put it on the boxes than I do when I was looking for a therapist for someone in my family. She wanted to see someone trained in CBT, and it was really hard to figure out if they really had the training or they just had some, you know, weekend thing or whatever it was. For schizophrenia, it's incredibly hard to find people who are trained to do that kind of therapy for people with schizophrenia. I mean, you're looking for a needle in a haystack. And to me, there ought to be more transparency and knowledge for people seeking help as to what they're getting when they actually get the help. Is it what we know works? Right now, we don't have that.
Yeah. And Karis, I know you don't want to take the Assistant Secretary's thunder, but
no thunder.
Is it okay to talk about your role within SAMHSA? Because I wasn't aware that there was an Office of Consumer Affairs, and so I'm sort of wondering, how do you represent the voice of people with lived experience, of family, of individuals, to the federal government? I mean, how does that work?
Sure. So in my role as the director of the office, and the office has been in existence for, I think Paolo will kill me because I don't know, but 20 years?
A while.
20 years, something like that. And I'm the second director of that office. And basically what we do is, it is not my voice that represents the whole nation. What we do is we do sort of stakeholder involvement. So we have lots of different mechanisms of hosting meetings, expert panels, dialogues, where we bring in people with a variety of experiences and touches with the mental health system or housing or criminal justice or employment. And we will have topical dialogue similar to what we're doing now, but it'd be more dialogue-y out there. Some presentation and then people dialoguing. And then we take that information and use that information sometimes to do white papers, sometimes to develop what is the plan of action or strategy that we might use for within our strategic plan. It might be about materials development, things like that. And then we don't do that just at the Center for Mental Health Services or at SAMHSA. We also do it with our federal partners. It could be with HUD. It could be with NIMH. It could be NIH. It could be a CMS. So we do partner with a lot of other federal agencies, and also like NAMI, MHA, NADAC. So also in the substance abuse world, or substance use world, we also do partnerships, recognizing that there is co-occurring. And there is a Office of Consumer Affairs in the Center for Substance Abuse Treatment as well. And we partner with them.
Okay. I mean, I find that very encouraging that our federal government would want to set something like that up. Tough question. Are people listening?
Well, so I will be clear about something. Working for the federal government is filling out forms to get the job that are very intense, and there is a box on the form where you have to disclose if you have a mental health disorder. And I was forewarned about that, and knew that I would have to be honest. You pay a huge fine if you're lying, and I was worried about whether that would impact my ability to get the job, especially when I had my clearance interview with the background person, and she said, "So tell me about this. You check yes on the mental health," and it's a long questionnaire. I tell you, I don't know how many questions, but it takes about 3 days to fill out. And I said, "Yeah, I do." And she said, "So what's the diagnosis?" And I said, "Oh, Lordy May, here we go." And so I said, "It's schizophrenia." And she went, "What?" And I'm thinking, you know what? That is so not the right answer.
Wow.
It is not the right response.
No,
It's not what I'm looking for. So I had to do a little education with her. And really it led to, there was already an executive order in place looking at question 21. Because there was interest in whether or not there was this intersection between, of course, violence and mental illness, and how can we protect our government employees. And I got to serve on a group working with that executive order so that they could have a better understanding of, okay, you have to ask the question's not going away. My thing is, how do you ask the question? How does the person engage and understand the answer to that question? What does it have to do with violence in the first place? What are you really looking for? And what they were really looking for was behaviors of concern that they'll find regardless of if you have a mental illness. So we really help separate that out, and then to couch the question in such a way that it won't prevent people from seeking treatment, prevent people from applying for positions, but really say that we just want you to be open and honest, and we do encourage people to seek treatment, and we do know people can work and sustain jobs in the federal government and have a mental health condition. So it's a lot of work like that too.
Yeah. I mean, this is a large area of stigma in our country. These sort of employment questions. There's a whole issue around for physicians licensing questions that are different state to state. And a similar question, have you ever had a mental health condition? Well, depression or anxiety, these incredibly common conditions, and people are faced with the idea of, oh, well, if I answer this in the affirmative, I may put my license in jeopardy. That's stigma. right? Because it's not asking, is there anything that could prevent you from doing your job? It's asking you, do you have depression, anxiety, schizophrenia, whatever it might be. Mary, people know NAMI, right? It's very well known.
Not as many people as I would like.
Oh, really?
I'm working
Okay.
on that.
I was going to say, you have a great brand.
It's on my list.
How is it, maybe for this audience, if not everybody knows, how does NAMI work to bring in the patient voice, the consumer voice, and the family voice? Because that's a central part of your mission.
Oh, absolutely. Well, I think we do it through our advocacy. As Pete said, I serve on the Interagency Serious Mental Illness Commission along with him. We also do it through our education programs. So we have provider education programs, teacher education programs, and the point of those programs is to bring the lived experience to those providers and educators, to take them through the eyes of the person living with the condition and their family. What does it mean? How are you treated? And I can give you an example. We did something with a hospital system where we showed how it felt for that individual when they came into the hospital and all these staff like sort of swarmed around them and started taking things and doing things. And you could really feel it when you were watching it. But for the hospital staff, that was like standard protocol. Like it wasn't a big deal to have all those people standing around trying to do their jobs. And we showed the impact it had on the person, and then we showed it if it had taken place a different way. If just one or two people had tried to engage in a conversation first before you were grabbing their shoes off and doing all this other things to them. And so we try to make it really concrete on how what happens in a provider setting influences the person and their family and can make a big difference as to whether someone stays in care and continues or really says, I want no part of this. So we spend a fair amount of our time working on that. We educate police. So Pete mentioned CIT training. Many NAMI members are very active in that training. They tell their stories, and that helps the police officers see things from a new lens. And I myself have been told by countless police officers how impactful that is for them. It makes a big difference. And if we want to bring that number down of how many people with mental illness die or are injured in encounters with police, we're going to have to obviously add to the mental health service system and also continue that effort training police officers.
And can you talk a little bit about family to family and peer to peer?
Sure.
Because when I'm working with patients who are interacting with NAMI or family members, what they talk about is the sense of like, oh, I'm not alone anymore. Like, I think the education is important, but for them, it's being part of a group that is working together to deal with this.
Absolutely. So family to family and peer-to-peer are classes that are for families and people with lived experience, and they're multi-week classes. And it's exactly what you just said. People come and they share their stories. So class 3 and family to family, everybody shares their stories, and there's an incredible bonding that takes place. And it goes to that point of empowerment that I was talking about, because people feel empowered from the fact that they're learning a lot that they had no idea. I mean, many come in, and it's really quite shocking to me how little people actually know about their health conditions. And if you go to hospitals and see what people get upon discharge for other conditions versus mental health, it becomes more understandable. But they know very little, and so we're teaching, so that's empowering, but then also they're hearing from everybody around them. And they're learning that there's an organization that's actually out there to help fight these issues. So we also have a class about becoming an advocate, and that piece of empowerment where you go from this is something happening to me to this is something that I'm going to draw meaning from and do something with to change the system. Either I'm going to change it by being an educator or a presenter, or I'm going to fight stigma or do something else or public policy. So I'm going to get activated. And that's the next stage. So that's kind of how we look at it. Like, we give you the building blocks, and then we want to empower you to become one of those people fighting those social forces and fighting public policy. I mean, we took 1,000 people to Capitol Hill this summer to say, you are not cutting hundreds of billions of dollars out of our Medicaid. It will hurt us. And look me in the eye and let me tell you why. That's a big part of what NAMI does. And we had to get 1,000 people to come to Washington to want to do that. And that's a big part of our job, is helping people see that they can make a difference with their voice, whether it's at the county level. I've gone with my NAMI to fight for more beds in Arlington, Virginia, or it's at the state level where you're fighting for the mental health resources that seem to get cut all the time, or it's at the federal level where somehow somebody thought it was okay to take hundreds of billions of dollars out of the program that serves people with the greatest needs.
And just to echo some of the things that Mary's saying, because it's so interesting we're sitting here together, I was introduced to NAMI as a part of my discharge from psychiatric hospitalization. And I was introduced to Care and Share, which for my affiliate back in California, Care and Share was a program for families to talk about, be sort of supportive to other family members. And of course, I walk in the room and they're like, "Oh, so are you a family member?" And I'm like, "Sure, I'm a family member. This is a ridiculous question." And just told you how important my family is. Yes, I'm a family member. And they're like, "Oh, okay, so who's the consumer?" And I'm like, "Consumer of what? What do you think?" All of a sudden you get introduced to all this new language. And I had to, they finally said, "Well, who's the sick person in your family, dear?" And I was like, "Oh, that'd be me." And they were really thrilled to see me, not so much at the moment, but because that was their time and kind of in I walked. But as soon as they had heard that all of my family was all the way on the other side of the world, they enveloped me and embraced me. And I affectionately call them my NAMI mommies, because that's what they did. They mothered me and they really helped me and got me more connected, which is the reason why my a psychiatrist actually recommended that I go to NAMI, so much so that the next thing I know, they just grab me and go, "Okay, you're going to go take In Our Own Voice, and you're going to go do peer-to-peer, and you're going to go sit on our board," and eventually became the board president for the national board, and having to leave that to go to SAMHSA.
Wow.
So.
And I just want to mention getting in early, because that's another thing that NAMI's been working on, and we were very fortunate to have Mrs. Gore support us to get in the program called Ending the Silence into high schools. So we're going into high schools and doing presentations, and the secret sauce of the presentations, and this won't surprise any of you, is a young adult who comes in and talks to the students about mental illness. And the idea is to really early on try to change the stigma that's driving a lot of this public policy, try to encourage help-seeking behavior, and try to help people support a friend. Those are really the things that we're trying to do with those programs. So we're really trying to get in early. One of the few things we know about mental illness is that if you intervene early, you can make a tremendous difference.
And the other thing we know is the power of personal story and having positive interactions with people who are living with mental illnesses. It is evidence or in literature and in research shown to reduce all sorts of stigma, including social distancing. So a lot of times people will think, "Oh, if I just do the education and tell people about mental illness, what it's all about, that will actually reduce stigma." And what it does is, yes, it might help people have a better understanding of what it is, but it actually increases social distancing, and then the isolation that we struggle with persists because people don't want to have anything to do with us, quite frankly. So again, sort of NAMI provides, and other spaces provide opportunities for us to feel like we belong. But I'll be quite honest, I have, and this is Karis Myrick speaking, remember my slide disclaimer, I struggle with things where I'm told, when I came into the mental health system, I was told I was a member, not a member of an insurance policy, I get that, but I was suddenly a member of this club that, quite frankly, if I had to tick off a box, I would not have ticked off the box. So I didn't appreciate being called a member. I understood why, because of people not having a sense of belonging, but it was really hard for me to kind of wrap my head around that. And I was telling Mary, and if somebody could go to my second slide, I was telling Mary this year that it's the first time I've had a really serious health condition. And when I found out that I had lost my voice, basically, is what happened. And when I went to the emergency room, I had totally lost my voice, and my whole neck was just sore. Everything was sore. And I had to go to the emergency room 3 times, and the 3rd time, they finally said, "Well, look, we see that you're taking medication for a psychiatric disability. Are you sure it's not in your head?" And I'm like, as much as I would love to sound like Lauren Bacall, no, it's not in my head. And I'm going to sit here until you treat me. And eventually what they found out was that I had a massive lump on my throat, which was really on my thyroid. If you could click next, on my thyroid. And I ended up having thyroid cancer and having to have my thyroid and parathyroid removed. And it was really striking, though, that 20 years ago I had been in the ER because of a car accident, and the same thing happened. So sometimes I think about policy, I think about people, I think about processes, and I think about the place. So the policy around like the electronic health record is probably okay as far as protections are concerned. I mean, I'm not going to go all into that, stealing thunder, but how it got executed by the person, not so good. So they see that I'm taking a medication, and then suddenly up comes a discrimination. That is not supposed to happen. But also, I show this slide because it's a reminder to me of what it feels like when you have schizophrenia and nobody sends you a dang get well card. And even if I don't believe I have a mental illness, which I didn't, I thought I had holes in my brain, just take a picture of it and you will see, which my doctor did. I don't know how he got that paid for, but I didn't have holes in my brain. But anyway, that's neither here nor there. So, but the point of it is that if somebody had said, I'm thinking about you, I really care about you, I hope you stay in this world, or something like that, it would have been something. I got nothing. But when I found out I had the thyroid issue, I got a buttload of cards. Oh, excuse my French. I got a lot of cards.
Is that French?
Yeah, well, they speak it to you in the hospital. They ask, are you going to participate in the milieu? I'm like, what? You say I'm sick, but I'm supposed to participate in French? What? But anyway, so the whole system sometimes to me is really kind of interesting, and how we understand what's happening is really interesting. So I got all these get well cards. And then my endocrinologist starts asking me about depression and ending my life, and I'm thinking, oh gosh, here we go. And she said, no, that can happen when you have thyroid disease. And I'm like, really? And I said, well, actually, and so I tell her a little bit, not terribly much. And I said, if I had said yes, would you have known what to do? And she said, yes. And I said, oh, that's great. So first, she was trained well to ask. She was not afraid to ask about depression. She was not afraid to ask, would I end my life? Secondarily, on discharge, instead of getting huge discharge paperwork, I got a postcard that told me the 5 top things to do, plus the big paperwork. It was amazing. So why don't we do that in mental health? It's pretty easy. I mean, it's just a postcard.
So I just want to point out, I'm going to ask for questions from the audience soon. So we're going to keep talking a little bit, but please stand up. As Tony said, it is not acceptable to not have questions. So go ahead and get your questions ready. Mary, you want to say something?
I just want to pick up on what Kara said about the difference between what's written and then what gets enacted. And we see this a lot in communications with families in the healthcare world. I mean, we hear it all the time that families feel like they're excluded, like the system is almost trying to separate out the individual and the family member. And one of the reasons that NAMI really strongly supports early episode psychosis programs, there's many reasons, but one of them is that their default is that the family will be involved. Like that's the norm. That's like what they expect to happen. And they do everything they can to make that happen. And so their rates of family involvement are sky high, as are their rates of continued engagement in the 90 percentiles for some of these programs for 20-something-year-olds, which is really high. But the reason is because they orient the whole thing in that manner. And they orient it toward recovery as well. They say, what do you want to do for a job? You know, relationship. We want to stay in school. They don't start with, oh, you have this illness and you need to take treatment and you're going to be on this treatment forever. They start with, what do you want to do? And then they link that. And so it goes to Karis's point about so much of this is, how are you approached? Is are you approached as a person with dignity, with respect, with acknowledgement of the goals that you have, and it's about you? Or are you approached with, this is the system, this is how we put you in this box, as she said, you're a member, and this is what your path's going to be, says we. And you're going to do it over here, and your family's going to be over here because we have this thing called HIPAA, so you don't have to share. So you don't want to, right? Sign right here. So,
Right. Don't make it complicated for us by sharing and having to bring in the family.
I think he was...
Question in the back, Winston.
Thank you. Winston Wong from Kaiser Permanente. And thank you, Mary and Kiris, for not only being champions for this work, but also sharing your personal stories. So curious, you mentioned in your personal history about not finding a psychiatrist as you relocated for your condition. I was wondering if you could illuminate that a little bit more. Was it around the issue of the amount of time that psychiatrists anticipated that they would have to invest in your therapy and your condition, or was it also a question of whether the compensation or the remuneration for the kinds of services that you might need became a barrier?
Well, considering they didn't even want to talk to me, I can't really tell you. I mean, if I had to guess, and this would just be an educated guess, it may be around their belief that there would have been a lot of time needed. I have a full-time job, so how much time are you going to spend with me? Not much, because I got to go to work. So this idea that you're going to be spending an inordinate amount of time with me was kind of curious. Secondarily, so it may be a preconceived sort of notion. It may be that they're really not trained to do so. And I don't want to work with somebody who's not trained to work with somebody with schizophrenia. That doesn't make any sense to me either. So I'm glad if they're saying no because they don't have the skill set to do so. I didn't really press the issue because it became, I was telling somebody the other day, and I've never really used this word ever, but I was telling somebody the other day that I had this moment of realization that schizophrenia for me has been a thief, and it's stolen from me, and I'm pissed, and I'm angry, and I'm very, very sad about it. And some of the stuff I can't get back. And I might be able to sit up here and talk about it, and that might be great because I've had the experience, but there are things that have been stolen on the front end. And as Pete said, our lives are ending earlier, so there are things that are trying to be stolen on the back end, and somebody wants to mess around with me and tell me they're not going to treat me. That's unacceptable. It's so unacceptable, I don't have words for it. And I shouldn't be a victim of a thief of an illness. I'm not a victim of a thief of them taking my thyroid. They engaged my father. They asked me, how do I want my father involved? Who's important to be involved with me in this whole process? They gave me 2 cards, one for a cancer support group, one for just a thyroid disease group, straight out the bat. That didn't happen immediately for me in mental health care. And I don't understand why. If we're talking about parity, let's really talk about parity. This isn't parity. So sorry for my passion, but it really is something I'm still mourning, I think, and I hadn't realized that there's still some mourning for me around some things that I've lost that I will never get back, and also recognizing that I've gained a lot too, and this has been a phenomenal experience, just kind of one I wish didn't happen the way it did, and hoping that it doesn't happen this way for other people. I hear Pete's story and his son, and I'm thinking, well, Dad, that's me, but I'm older. How is that possible? How is it possible that it's still happening?
No apologies for passion.
We're the passion panel.
Okay, passion panel.
We're the passion panel. Yeah.
Nathaniel Counts, Mental Health America. So one sort of systemic way we're addressing this, right, is by consumer advisory groups at sort of all levels of the healthcare system. And we're doing a pretty good job, I think, in the sort of initial phases of putting consumer groups on boards and all sorts of things. But unfortunately, last month, I think it was the American Journal of Public Health, they came out with a systematic review saying basically there's no evidence or empirical evidence for the effectiveness of consumer advisory boards. And meanwhile, there's mountains of evidence for the rest of all of the value-based payment structures happening. And so I was wondering what your thoughts are about sort of developing the science of patient engagement of every level so it doesn't become like a little hat we put on the top of value-based payment.
You want me to do? So, I mean, Nathaniel, I think part of it is the difference between being on an advisory board and being actually part of the solution. If I think about it, I could spend every minute of my day on an advisory board. I mean, we're asked, you're asked a lot too. And so, I think it's the difference between that and someone really wanting to know what the journey is and wanting to look at the journey at every stage and meaningfully figure out if that journey is working and helping that individual and family. And so I think that, looking at advisory boards and what is the level of engagement. Is it, you sit there, or is it you're really driving what happens? And so I wonder if the study was done somehow, parsing out the ones that are in name versus a more meaningful engagement of that journey, what we would find. And that's what I would suggest, because, I tell people all the time, I'm not interested in, just being there to be window dressing. And I feel many times like I am asked for window dressing. I will just say that right out there. Because they want to be able to say they had me on the group, rather than they plan to meaningfully make sure that the individual and family voice is engaged in what they are doing from, and the issue too is, are you there in the beginning? Or are you coming in later where they say, oh, bless this, say this is okay, or give me comments on it, but it's all drafted, so you can comment, but it's due, so it's got to be commented on. So, there's just differences in level of engagement that I think are critical if you're going to research these things.
Yeah, totally agree.
In the back.
Hi, my name's Kim Burton. I'm an educator and an advocate on behalf of older adults and late life behavioral health issues. And I have a couple things. First, I want to just say, after the first speaker, yeah, I lost my place. That what we are seeing are increasingly people with behavioral health disorders, not necessarily in jails, but in nursing homes, in assisted living, and long-term care settings, as we have people with serious mental illness living longer than they have before. These are our new quote-unquote jails, or places where we are, where people are landing. I wanted to ask about the use of mental health advance directives, and if you feel that mental health advance directives are a tool that we could be using to perhaps change treatment. And then the other thing I wanted to ask about, so in the older adult world, we have to put dementia under the umbrella of behavioral health. And I know today's about mental illness, but one of the things that we're looking at is the workforce, and our psychiatric community and the people who do the work for mental illness are also doing the work for the behavioral and psychiatric symptoms of dementia. So I was wondering about how you feel about embracing other illnesses or other disorders that have psychiatric symptoms.
I can't answer the latter. I can talk about Olmsted, and I know Mary, she's the queen of Olmsted, but just because we just recently had a meeting at SAMHSA around Olmsted, which is a state, you could talk about what it is at the federal level, but basically it is around psychiatric boarding in nursing homes and people not being able to live in the community of their choice, and ensuring that states have what they need and follow their Olmsted ruling in order to place people in community and not board them in nursing homes. So I think that's work that we continue to do at SAMHSA. Dr. McCants-Katz was not able to make that meeting. We did have, again, federal partners aligned with us. It was a very large meeting with HUD as well as CMS and SAMHSA and other agencies. So it's work that we continue to do, and we do recognize that that's a huge problem. Again, from a personal perspective, it's like I think I've touched every part of the system in every different way. My mother had to yank me literally out of one of these situations and fight like a dog to get me out, because it was the only option that was being offered to me to be in a nursing home. And I was young. I was very young. And the people that we were seeing in the nursing home were people on oxygen tank and all sorts of, and it was like, my mother was like, no, this is not gonna happen. So, but I'm fortunate to have parents who can do that. Not everybody has that. And so we continue to work on that.
Yeah, So for those who don't know, Olmstead is a Supreme Court ruling where the court said under the Americans with Disabilities Act you had to be served in the most integrated setting appropriate to you. And when I worked at the Office of Civil Rights, I did quite a bit of work under that ruling. And as Kara said, it applies to people who are in nursing homes. So you will see some litigation that has gone on. You'll see some policy agreements that have been made to try to move people from nursing homes into the community. But it's very scattershot where there's been complaints or where someone's investigated, where there's actually a will. And I think in so many of the things we've talked about today, whether there's a will to change it, is really important. And then the financing, as Pete said, that goes with that. With nursing homes, you can do things like waivers that allow you to serve people in the community. In these cases, I just think that the states have not done what they could do to serve people in different settings. In other instances, you can't. The IMD exclusion, which is the Medicaid program, doesn't allow you to bill for facilities that have over 16 beds. And the implication of that is that it is quite difficult to do a waiver from that facility. So there are reasons why structurally we see some of the things that we see. You asked about advanced directives. We at NAMI are very supportive of them. You can find information on our website about them. I think they are a partial answer. They contribute positively to helping people make decisions when they're in a difficult situation. They're not a perfect solution because there aren't any. But they do contribute, and we certainly support that idea. And the last one about dementia, I would just say that we collaborate with organizations like the Alzheimer's Associations and others in a number of ways. We collaborate on our advocacy. We work very hard on research. We all need more research on the brain. I mean, one thing we haven't talked about is the fact that in our field, there's been really very little breakthrough new therapies that you can see compared to like oncology and other areas where you're seeing things all the time. So we certainly collaborate a lot on pushing for more research to get us to better solutions there. In terms of our own advocacy, I mean, I think that we feel like there are other organizations for whom that is their primary area, and so our primary area is mental health conditions like some of the ones we've been talking about today.
So I think we have time for one more quick question, if we can.
Great, thank you. Denise Solzback from the National Technical Assistance Network for Children's Behavioral Health. My question is actually for both Pete and Mary. Can you talk a little bit about the timeline for ISMIC? I mean, 14 commissioners can't possibly come up with everything they need to by the report to Congress due in December. So what's the long-term process, and how can people contribute?
Well, I think Dr. McCants-Katz is coming this afternoon, and she is, I think, extremely committed to the process. She has indicated that this is really a tremendous priority for her, and she will be working on the timeline from here. Our initial report is due to Congress in December, right, Pete? December. That's an initial, though, and then there's quite a while before, by statute, we have a report due. But I think that we are all working, and Dr. McCants-Katz will ultimately decide how we will have interim markings to check on our progress as we move forward. So I would urge you to ask that question this afternoon, but those of us on the group are very grateful for the leadership that she's shown there.
All right, so it sounds like we'll get more on that this afternoon. Can we get Karis's last slide up, please? Are you able to do that?
Not that. Well, that one's very interesting, but not that one.
And colorful.
Not that one. That one's very interesting too, but not that one. This one. So the reason that I want to show this one is the first thing I talked about was what happened in my care for my thyroid issue and getting cards. And I was in CVS about 2 weeks ago, and they have this caring happens when life happens. And there are all of these cards that are inspirational, they're get well, they're all different. And then they have these informational cards for like after surgery, for medical conditions, for cancer. And lo and behold, they had one for mental illness. They only have 5 cards, these 5 informational cards. And the fact that CVS and Hallmark decided to do mental illness, I don't know how. I've never seen anything like it. But when I thought of my talk, and I used that slide in the beginning of the greeting cards and the get well cards, and here it is, not a couple of months later, I see this in the store. I felt very hopeful. And I just wanted to leave everybody with that piece of hope that people are doing something, and it's not always going to be the mental health system. It's going to be people like Hallmark.
All right.